Greetings to you all. My name is Daniel Akama Nyamweya, and today I'll be presenting my project titled AI Clinical Decision Support in Predicting Hospital Readmission for Diabetes Patients. This project focuses not only on predictive modeling but also on explainability and how artificial intelligence can integrate into real clinical decision support systems. Onto the problem overview. The core problem I'm trying to address is hospital readmission among diabetic patients, an issue that places substantial burden on health systems. My aim was to simply build a model that predicts readmission, but to understand why the model makes certain decisions. This aligns with modern expectations for artificial intelligence in healthcare. Models must be accurate, interpretable, and they must also be workflow friendly and clinically meaningful. So throughout the project, I focused heavily on explainability, real-time decision support potential, and overall usability. Onto the literature review. Some of the studies that I reviewed in the course of this research project, for example, work by Chadad, highlights that clinicians trust interpretable models more than black box systems, like deep neural networks. This is essential. It's especially important for high stakes predictions such as readmission risk. Another important study that I looked into was one by Struck, which examined a large diabetes inpatient dataset and showed how clinical factors like the HbA1c measurement correlates with readmission. The dataset forms the foundation of my research and has been validated repeatedly in peer-reviewed studies. The broader clinical decision support literature also emphasizes the necessity of user-centric systems, ones that integrate quite easily with clinician workflows. Because this reinforces why this such studies reinforce why explainability and usability are key central figures in these particular studies. I looked also into the literature surrounding the dataset, particularly source validation. I worked with the UCI diabetes dataset that ranges from the dates 1999 to 2008. It's a well-validated dataset. Extensive research has been done on it, and it is continually being used in to predict real-world patient characteristics. A lot of lab results have also been inculcated in it. Diagnosis, treatments, and also readmission outcomes have also been evaluated against it. Because of this reason, it has been vetted multiple times in multiple studies, and is considered quite a good data set for clinical modeling. XAI explainability, as I mentioned earlier, very key. Critical studies such as the one from Mienye talk about heavily about the influence of SHAP values and why they're important, particularly when it comes to interpreting feature contributions to the possible outcome. Onto the justification of why the population was chosen. As I said earlier, we decided to work with the UCI database ranging from 1999 to 2008. The dataset is quite large, 100,000 hospital admissions, or across 130 hospitals, and the dataset is quite intriguing, or because it has a lot of demographics, it has a lot of hospital and admission details, it has a lot of ICD-9 diagnosis codes, a lot of medication codes, it has a lot of lab values, and finally, it has a lot of comorbidity instances. So those are some of the reasons that make this dataset quite good for this particular study. As there you have it, some of the demographics you can see: age, gender, race, You can see it also has some of the hospital and admission information, a lot of medical diagnosis in terms of the ICD-9 codes. It also has a lot of treatment and medications, as I said earlier. Lab tests, comorbidities are in the data set. There you have it. These are some of the features that we were able to engineer from the data set itself. So we were able to come up with age groups where we converted some of the numerical ages to categorical risk buckets. So you could have age ranges from 0 to 10, in buckets of like 10 years, so as to make an analysis quite easy. We also came up with comorbidity score, which is basically the number of diagnoses a patient has. Total medications was also another feature that we engineered, where we basically aggregated the medications someone has. And finally, we checked whether the patient was previously readmitted. So we captured the patient's readmission history as one of the features that we engineered. Onto EDA exploratory analysis. In EDA, we found that diabetes is more prevalent in older adults, which aligns with a lot of clinical literature. Another significant observation was the severe class imbalance between the readmission column. Most patients were not readmitted, while only a small minority fell into the less than 30-day or after 30-day readmission categories. So this imbalance had a major implication on the classification aspect of it. We also did a bit of, so this is just a continuation of the various features that we looked into. We looked at the frequency of insulin, the frequency of metformin, the drug frequency of some of the drugs such as glimepiride, and also some other drugs, just to see the frequency or among the diabetic patients. Some of the bivariate analysis that we looked into to help us uncover some of the relationships between features. And we also did correlation analysis just to see whether there was a strong multicollinearity among the features. And we found no significant correlation problems between the features, indicating that most of the features were actually important to the study. In terms of the pre-processing implemented for this particular study, we resorted to removing columns that have more than 40% of the data missing, because the imputation at that point would just be introducing a lot of noise. We also did a categorical features encoding, where 33 features were encoded from two numerical figures, otherwise known as dummy variables. Outliers were also removed, and we focused heavily on three key features: time in hospital, the number of lab procedures, and the number of medications. Because according to the studies, we found that these particular features were more likely to have outliers in most of the cases, mainly due to human error. Or as I said earlier, we also introduced some new features: age groups, comorbidity score, and total medications. One thing that was clear, leakage was if we did not take into account leakage, would be a huge problem, and thus we resorted to patient level splitting, where instead of using the normal train test split, we implemented the group shuffle split, which ensures that the same patients go into the same set way, be it train or test. So you don't have two or more patients. You don't have a patient appearing in both the train and the test, which clearly is leakage. So that was a very crucial step. When it came to modeling, there you have it. We had to apply SMOT due to the severe imbalance, because the data set was highly imbalanced. So you can see the distribution before SMOT and after SMOT. Then we moved swiftly into fitting of the model. So in this particular study, we resorted to using four models: one baseline model, and then three complex models, as I would put it. The evaluation metrics were there, and there you can see them there. You can see across the board, most of the models performed poorly. Although XGBoost performed the best, are among the metrics. Overall performance across was moderate. You can see AUC for many of the models was in the 60s, which is not it's not really nice. It really showed us the complexity of predicting readmission risk and how difficult it is using only the available structured data. Complexity, clinical complexity, contextual information, and also there was an inherent lack of temporal history in terms of tracking time from the data set. So some of these things contributed heavily to to the values that you're seeing. So in line of that, we decided, okay, let's look at the explainability side of things. So we decided to look at the Shapley values for the Shapley. We decided to do the Shapley analysis for this particular data set. So given the moderate performance, we shifted to explainable artificial intelligence, and we mainly used Shapley additive values. So it allowed us to analyze both the global patterns, like where features, like which features influence the predictions the most, and also some of the local explanations as to what contributes to the outcome for a particular patient. So the summary plot, as you can see, revealed a key thing that gender, race, and age were among the most influential factors where in terms of readmission risk. There you have it. You can see it from the Shapley summary plot. From the global bar plot, you can see that the global bar plot ranks some of the features that contributed heavily towards readmission risk. Moving on to some of the local interpretation analysis that we did, we saw that for a particular patient, say for example, patient on index 10, we found that the Shapley waterfall plot showed that gender and age pushed the prediction towards the positive side of being readmitted, while race reduced the probability for that particular patient. So gender increased by 0.09, age increased by 0.07, and race decreased by 0.06. So this level of transparency is essential, especially when it comes to clinical decision support. In terms of conclusion, given the moderate performance of the predictive models, we decided not to deploy a full user interface because we found that it would not be appropriate. The user interface would imply that the model is ready for clinical decision support, and clearly from the metrics we are not on that stage. Deploying a weak model, even though it's polished and it has been trained well, can cause a lot of trust issues and can lead to harmful decisions. So for that reason, we decided to stop at the explainability section. Sharply allowed us to undertake that. So that's why we applied Sharp. Overall, this project, it highlights that while prediction readmission is feasible, it is possible. A lot of input has to be taken into consideration. Significantly better data and even more advanced modeling techniques need to be applied to this particular clinical decision support area. Readmission, as you can see, our outcome was not binary; it was multi-layered. So we were predicting more than three outcomes, up to three outcomes, which can be a bit tricky. So more advanced, complex modeling techniques need to be applied onto this data set. Moving on to the positive side of things, in terms of next steps, we plan on focusing on four key areas. We want to expand the explainability side of things. So we want to include even more dependence plots and more granular feature analysis, just to make sure and actually elucidate clearly what the models are deciding to give us the outcome. We also want to improve on the feature engineering. We want to engineer even more features, such as the temporal features that we are missing. We want to come up with some things such as the comorbidity indices, and we also want to investigate some of the medication and lab patterns. In terms of the third thing, we would in the third thing we plan to work on is we want to also inculcate some of other advanced models, such as transformers and also some survival models, and see how they perform in this particular data set. Then and then only, after getting the metrics and we see that there's an improvement in the overall metrics, then we can now start thinking of deploying it as a UI. So that was the project. It was a 4 month long project, but we learned a lot. I hope you enjoyed it. Please do reach out if you have any questions, as this is an ongoing project. So we plan to expand it into the future. If you'd also like to be part of the team, you can always reach out. These are some of the references that we have on the particular project. And we hope that you found this highly insightful. Thank you.